Welcome to part D of week 6, our final section this week. This is where everything comes together. In parts A through C, we learned aggregate functions, group by, having, subqueries, indexing, and query optimization. But now we're going to apply all of those skills to something that matters enormously in real life of the healthcare executive. Population health analytics, and HEDIS quality measurements. If you work in a health plan, or a hospital system, or a community health center, or really any organization that reports quality metrics, the material in this section is directly applicable to your job. The SQL patterns we cover here are the same patterns used by quality teams across the country to measure and hopefully improve healthcare delivery. What are our learning objectives for this portion? By the end of this part D, 6D, you should be able to accomplish 6 things. First, to define population health analytics and understand its role in modern healthcare delivery. Second, understand what HEDIS measures are and who uses them, which, to be honest, is essentially every major health plan in the United States. Third, to identify the key categories of HEDIS measures. Fourth, connect the SQL aggregate queries that we've learned and explored in parts A and B to some real-world quality measurement workflows. And fifth, apply group by and aggregation to calculate actual quality metrics from our X-Health sample database. And sixth, understand the fundamental structure of a quality measure, which is the denominator, numerator, and rate calculation pattern that underlies every HEDIS measure. All right, this first section introduces population health analytics as a discipline. Up till now, our SQL queries have mostly focused on individual patients or small groups. Population health flips that perspective. Instead of asking about one patient, we ask about thousands or even hundreds of thousands at once. The questions change from what is this patient's blood pressure to what percentage of our hypertensive population has their blood pressure under control. That shift in perspective is what makes aggregate functions so essential in healthcare. Population health analytics is the practice of analyzing health outcomes across groups of patients rather than just individuals. The goal is to identify trends and disparities and opportunities for improvement at the population level, and then use that information to drive better outcomes for entire communities. And there are 5 key activities within population health. You can see them on the slide. Disease prevalence tracking asks how common a condition is within your patient population. Risk stratification identifies which patients are at highest risks for poor outcomes so that you can target your interventions. Quality measure reporting, which is the bulk of what we will cover today, tracks whether your organization is meeting established standards of care or not. Then health equity analytics looks at whether outcomes differ across racial, ethnic, socioeconomic, or insurance groupings. And preventive care gap identification finds patients who are overdue for screenings or vaccinations. Let's look at the quote at the bottom of this slide. It frames it well. Questions like, how many of our diabetic patients have their hemoglobin A1C under control? Or which insurance groups have the highest emergency room utilization? Are population health questions. They cannot be answered by looking at one patient record. They require aggregating data across your entire patient population, which is exactly what SQL skills from this week will enable. This slide shows the end-to-end pipeline from raw clinical data to actionable insights. Understanding where SQL fits in this pipeline helps you to see the big picture. Step 1 is data sources. In a real healthcare organization, data comes in from many systems, like the electronic health record, EHR, for like clinical encounters. Then there are claim systems from billing and insurance data. There's laboratory information systems for lab results, pharmacy systems for medications, and sometimes there are even some patient surveys for experience data reporting. So step 2 is to integrate. All of that data gets aggregated into a data warehouse or some analytics platform. This is where data from different systems get standardized and linked together so you can query among them. Step 3 is analysis. This is where SQL comes in. Aggregate functions like group by, case, subqueries, and everything else that we've covered this week are the tools used to transform raw data into meaningful metrics. Step 4 is reporting. The results of those SQL queries feed into dashboards or quality reports and HEDIS submissions. This is what leadership, quality teams, and regulators actually see. And step 5 is action. The whole point of the pipeline is to drive interventions, to allocate resources, and change policies to improve outcomes. The key point is that SQL aggregate queries are the engine powering steps 3 and 4. Without the ability to write these queries, the pipeline stalls. Here's a concrete example. Let's look at this carefully, of a population health query using our xHealth database. This query calculates disease prevalence by age group, specifically looking at diabetes rates across different age brackets. Look at it carefully. The case expression creates 4 age groupings: pediatric for patients under 18, then 18 to 44, 45 to 64, and 65 and older. Remember the extract year from capability we have? That allows us to calculate each patient's current age directly from their date of birth. Now, the first count gives us total patients in each age group. The second count uses a case inside it to count only patients who have the diabetes diagnosis. How do we identify that? By using the ICD-10 codes that start with E11, which is a code family for type 2 diabetes. Now, notice the left joins. We use the left join from patients to encounters and from encounters to diagnosis because we want to count all patients, including those who may or may not have encounters or diagnoses. Now, if we had used an inner join, patients without encounters would be excluded from the total count, which would skew our prevalence calculations. This query pattern, grouping by a demographic category and counting both the total population and a subset meeting some clinical criteria, is the fundamental building block for population health analytics. This reference table maps common population health metrics to our SQL approaches used to calculate them. For example, the first, disease prevalence. It's the percentage of your population with a given condition calculated as a count with a diagnosis filter divided by the total count. Then secondly, the utilization rate measures how many visits patients have per year calculated as total encounters divided by the count distinct. Screening compliance, on the other hand, tracks what percentage of eligible patients received a recommended screening using a count with a procedure code filter divided by the total eligible population. Medication adherence measures the proportion of days a patient has an active prescription, which involves date calculations with sum. Then readmission rates tracks patients returning within 30 days of discharge, typically calculated with a self-join on the encounters table. And cost per patient uses average or sum on claims data, grouped by population segments. Each of these metrics uses the SQL tools we've already learned. The key is knowing which combination of aggregate functions, or joins, and group by clauses to apply to achieve each metric. Let's go into the HEDIS measures. We're moving from general population health concepts to specific measurement framework that dominates the healthcare industry. HEDIS, if you work in healthcare in any capacity that touches quality, compliance, or reporting, you will encounter HEDIS. Understanding what it is and how it works is essential. HEDIS is the Healthcare Effectiveness Data and Information Set. It is developed and maintained by the National Committee for Quality Assurance, NCQA. Let me give you a sense of scale. More than 235 million people in the United States are enrolled in HEDIS plans, or in plans that use the HEDIS quality assurance system. So over 90% of U.S. health plans participate. So this is not just a little niche framework. It's the dominant standard for measuring healthcare quality in America. HEDIS provides standardized measures that allow an apples-to-apples comparison across different health plans and different providers. Without this standardization, one plan might define diabetes control differently than another plan, making comparisons meaningless. HEDIS solves that by defining exactly what counts, exactly who is eligible, and exactly how to calculate the rate. The measures are updated annually to reflect current clinical evidence and best practices. So the key takeaway is that HEDIS measures translate clinical guidelines into measurable standardized metrics that can be calculated from healthcare databases. That translation from clinical guideline to an SQL query is exactly what we're going to practice in the next several slides. HEDIS measures are organized into several broad categories. Effectiveness of care is the largest and most clinically focused category, covering things like diabetes management, blood pressure control, and cancer screening rates. Access and availability of care measures determine whether patients can actually get to preventative services. Experience of care captures patient satisfaction through CAHPS surveys, which is a separate data collection process. The utilization measures track patterns like inpatient admissions, outpatient visits, emergency room usage. The health plan descriptive information covers enrollment, demographics, and provider network details. In the final category, measures collected using ECDS represents the growing set of measures that rely on the electronic clinical data systems rather than traditional claims or manual chart reviews. So things that we can do electronically, which are very pertinent in terms of your SQL experience. So the last category is important to you, and it's important that you understand these in terms of completing your HEDIS calculations. For HEDIS is actively transitioning from a model where data quality was collected through manual chart reviews and administrative claims to one where data flows directly from the electronic health records or other sources into the data warehouses, and everything can be done automated electronically. So the transition to ECDS is exactly why database skills are becoming more critical for quality teams. The data is in the database, but someone has to write the queries to be able to extract it and measure. So how does a HEDIS measure work? Every HEDIS measure follows the same structural pattern, and understanding this pattern is essential. There are 4 components. The denominator defines the eligible population. Who qualifies for this measure? This is often determined by age or diagnosis or enrollment status or other criteria. For example, the comprehensive diabetes care hemoglobin A1C measure, the denominator is patients aged 18 to 75 with a diabetes diagnosis. The numerator defines who met the quality standard of the eligible patients who actually received the appropriate care. In our example, the numerator is patients whose most recent hemoglobin A1C result is below 8%. Exclusions define who should be removed from the calculation entirely. These are patients for whom the measure does not apply, even though they technically meet the denominator criteria. In our example, patients in hospice or with end-stage renal disease are excluded. So the rate is the final calculation, numerator divided by denominator minus the exclusions, multiplied by 100. In our example here, 72% of eligible diabetic patients had their hemoglobin A1C under control. This denominator-numerator exclusion rate pattern is universal across HEDIS. Once you understand it, you can translate any HEDIS measure specification into a SQL query. All right, this table shows the specific HEDIS measures that are most relevant to our xHealth Community Health Center database. These are the measures that primary care settings typically report. Comprehensive diabetes care, the CDC, which tracks the hemoglobin A1C testing, or eye exam referrals, and blood pressure control among the diabetic patients. Second, controlling high blood pressure, or the CBP, measures the percentage of hypertensive patients with blood pressures below 140/90. The colorectal cancer screening, COL, tracks screening rates for adults aged 45 to 75. Breast cancer screening measures mammography rates for women between the ages of 50 and 74. Cervical cancer screening tracks PAP and HPV testing for women from the ages of 21 to 64. The adult BMI assessment measures whether BMI is documented during outpatient visits. Medication adherence, measured by the proportion of days covered, or PDC, tracks whether patients on chronic medications are actually filling their prescriptions. And follow-up after emergency room visits, the FUM, measures whether patients with mental health or substance use disorder diagnosis receive timely follow-up after an ER visit. Each of these can be calculated, at least in simplified form, using the SQL patterns we are about to practice. This slide shows the universal SQL pattern for calculating any quality measure. Memorize this structure because you will use it over and over. The select clause has three parts. First, the count star gives you the denominator, the total eligible population. Second, sum with a case expression counts the numerator, patients who met the quality criteria. The case returns a 1 when the criteria met and a 0 otherwise. So sum gives you the count of the patients who qualified. Third, round expression calculates the compliance rate by dividing the numerator by the denominator and multiplying by 100. The from clause specifies the eligible population table or join tables. The where clause applies denominator criteria defining who is eligible and removes any exclusions. So what's the key insight? As it says at the bottom of the slide, every quality measure is fundamentally three questions: who qualifies, of those who met the standard, and what is the rate? That maps directly to the denominator. So if we have the denominator, the numerator, and the rate calculation, we can do a measure. This pattern applies to all of the HEDIS measures. Let's do an example. Let's do the hemoglobin A1C for our diabetics. What is the question? What's the percentage of diabetic patients aged 18 to 75 who had a hemoglobin A1C test during the year that were under observation? All right, let's walk through this queries line by line. We start with the patients table and join to encounters and diagnoses to identify patients with a diabetes diagnosis. How do we do that? We use the ICD-10 code like E11. Then we left join to lab results, because not every diabetic patient will have a lab result, and we want to count them in the denominator regardless. The where clause establishes the denominator, patients with an E11 diagnosis code who are between 18 and 75. The first count distinct gives us the total number of diabetic patients, our denominator. The second count distinct uses a case to count only patients who have the lab result with that LOINC code indicating they had a hemoglobin A1C. And we also want to be sure they had a result within the 2025 measurement year. That forms our numerator. And the round expression calculates the screening rate. Notice the use of count distinct patient ID throughout. This is critical because patients might have multiple encounters or even multiple diagnoses, and we want to count each patient once, not once per encounter or once per similar diagnosis. Now, 2 LOINC codes are used here because there are actually 2 commonly used codes for the hemoglobin A1C test. The 4548-4 for hemoglobin A1C as a percentage, and the 17856-6 for hemoglobin A1C as a fraction. Both are legitimate. Let's look at another HEDIS example, high blood pressure control. What percentage of hypertension patients have a blood pressure below 140/90? So this query starts from encounters, joined to diagnoses, filtering on the ICD-10 like I-10. This is essential hypertension. The count distinct on patient ID gives us the denominator of hypertensive patients. The case inside the second count distinct checks whether the systolic reading is below 140 and the diastolic is below 90. Both conditions must be met for the patient to count as controlled. So the important detail here is the correlated subquery in the where clause. It filters to only the most recent encounter for each patient by requiring that the encounter date equals the max encounter date for that patient. This is a real HEDIS requirement. Blood pressure control is measured at the most recent reading, not an average or at some random visit. This ties directly back to the correlated subquery pattern that we learned earlier this week. So this is a great example of how the skills from earlier parts of the week connect to the real-world applications. Without understanding correlated subqueries, you could not correctly implement this measure. And finally, the BMI assessment, the HEDIS BMI. We're asking what percentage of adult patients had a BMI recorded during an outpatient visit during the measurement year. So this query is structurally simpler than the previous two, because we join patients to encounters and then filter the where clause to adults aged 18 and older with encounters during the year of observation. The denominator is all such patients. The numerator counts patients where the BMI is not null, meaning a BMI value was documented during at least one encounter. So this measure is about documentation, not really about the value of the BMI itself. HEDIS does not care whether the BMI is 22 or 42 for this particular measure. It only cares whether the provider documented it. This distinction matters because it means the SQL only needs to check for the existence of a value, not to evaluate its value against a particular threshold. Notice again the use of count distinct to avoid double counting patients who have had multiple encounters during the year of observation. A patient with 5 visits where the BMI was recorded still only counts once in our numerator. Stratification. Stratification takes a quality measure and breaks it down by demographic categories in an attempt to reveal disparities. This is becoming increasingly important in HEDIS. The race and ethnicity stratification requirement, known as RES, now applies to more measures every year. And the intent is to make health equity gaps visible so they can be addressed. This query takes the blood pressure control measure and adds group by insurance type. Instead of getting a single overall control rate for the whole practice, we now get a separate rate for each insurance category, the Medicare, Medicaid, private, uninsured, etc. The hypothetical insight at the bottom illustrates why this matters. For example, if your overall blood pressure rate control rate is 68%, that might look acceptable. But if the Medicaid patients are only 55%, while the private insured patients are at 78%, this reflects a significant equity gap that the overall numbers mask. Without stratification, you might not see it. In practice, quality teams stratify by insurance type and sometimes even race, ethnicity, age group, and even gender. Each stratification reveals different patterns and potential interventions. But the sequel is the same group by pattern we learned in Part 6A at the beginning of this week, just applied to a more complex base query. All right, this slide demonstrates how to combine multiple quality metrics into a single summary query using union all. This pattern is useful for building dashboard views that show multiple metrics at a single glance. The query has three parts connected with the union all clause. The first counts the total active patients. The second counts distinct diabetic patients using that same E11 ICD-10 filter. The third calculates the average number of encounters per patient using a subquery that counts encounters per patient and then averages these counts. Notice the use of the : text cast. This is something we haven't discussed before, because the union all requires all corresponding columns to have the same data type, and our first column is a text label. We need to cast the numeric values to text. This is a Postgres-specific syntax. In other database systems, you would have to use a cast value as varchar instead. So this type of summary query is commonly used as the data source behind executive dashboards. Each row becomes a tile or card on the dashboard showing a key performance indicator. In a real quality program, you might have 15 or 20 such metrics on a single dashboard for your executives' use. All right, this slide provides a context on how database queries fit into the broader HEDIS reporting workflow. And there are two approaches currently in use. The traditional hybrid method combines administrative claims data with some manual chart review. A quality analyst identifies eligible patients from claims and then reviews a sample of medical charts to verify whether the quality criteria appear to be being met. This is very labor-intensive doing manual chart reviews. It's expensive and is limited to sample data, which is subject to errors, imprecision. The future is in the ECDS, the Electronic Clinical Data Systems. In that model, data flows all electronically, automatically, from sources such as the electronic health record or health information exchanges or claim systems. No manual chart review is necessary. SQL queries extract the data. Data warehouses aggregate across systems, and reporting tools format the results for NCQA submission. HEDIS is actively moving towards the ECDS, using that as its predominant reporting technology for many measures. And this transition is exactly why the skills you are learning now in this course are so valuable. As manual chart review goes away, the ability to write accurate SQL queries against a clinical database becomes the primary skill needed for quality assurance. The quality analyst of the future is someone who can translate the HEDIS measure specification into a validated SQL query. Now, HEDIS is updated annually. and the measurement year 2025 changes are worth knowing about because they reflect the direction this industry is heading. 3 new measures were added, including blood pressure control via ECADs and documented assessment after mammogram. This continues the trend of adding measures that can be calculated from electronic data rather than requiring a manual chart review. Now, 4 measures were retired, which happens regularly as NCQA refines the measurement set to focus on the most impactful and actionable metrics. The transition from hybrid to ECDS only reporting continues. More measures that previously required chart review can now be reported entirely from electronic data. For example, the race and ethnicity stratification requirement is expanded to cover more measures. This reflects the industry's growing commitment to making health equity gaps visible and measurable. And there's a greater overall emphasis on social determinants of health and addressing disparities. HEDIS is evolving from purely clinical measurements towards a more holistic view of what affects health outcomes. These changes reflect 2 major trends: healthcare's increasing reliance on electronic data and a deepening commitment to health equity. Both trends make database skills more essential, not less. All right, here are 5 practice examples to apply what we've covered in this section. Let me give you some hints. Exercise 1, to calculate the diabetes prevalence rate by insurance type. This combines the prevalence calculation from slide 6 with the group by on insurance type, similar to the stratification pattern we used in slide 17. Exercise 2, find the average number of encounters per diabetic patient versus non-diabetic. Well, this will require identifying diabetic patients using the diagnosis join pattern and then comparing encounter counts between the 2 groups. So think about how you would use a case expression or separate queries to split the populations. Exercise 3, calculate the BMI assessment rate by provider. And this takes the BMI measure from slide 16 and adds a group by on provider so you can see which providers are documenting BMI consistently and which aren't. Fourth, identify the top 10 most common diagnoses and their prevalence rates. This uses count with a group by on ICD-10 code and order by the count descending and limit to 10. For prevalence, you need to divide by the total patient count. Fifth, create a stratified report of average BMI by age group and gender. This combines the case-based age grouping from slide 6 with group by on both age group and gender using average on the BMI column. All right, we're getting near the end. What are the key takeaways for today for this portion, 6D? Population health analytics uses aggregate queries to reveal trends across patient groups. This is the shift from individual level to population level thinking that makes SQL indispensable in healthcare. HEDIS is the primary quality measurement framework used by over 90% of U.S. health plans, covering more than 235 million patients. Every HEDIS measure follows the same denominator, numerator, and rate structure. Once you understand that pattern, you can implement any measure. SQL aggregate functions combined with group by and case expressions are the building blocks for quality measurements. These are the exact tools we learned in Part 6A, but now we're applying them to real clinical quality metrics. Stratification by demographics reveals health quality gaps that overall rates might hide. And the ongoing shift to ECDS reporting makes database skills essential for quality teams because electronic data extraction is replacing the cumbersome and inaccurate manual chart review. So that wraps up all 4 parts of this week, week 6. Let me remind you of the big picture here. The assignments that are due this week. The SQL Lab 3 covers aggregations and subqueries. It's worth 50 points. This lab will test your ability to write the kinds of queries we practice across parts A and B. And the final project milestone is also 50 points. You need to submit your topic selection, your data source, a draft of your ER diagram, and 3 research questions. So this is an important checkpoint to make sure your project is on a solid foundation before you get deeper into the semester. It's going by quickly. Now, Quiz 3 covers material from the past 2 weeks, and it's 40 points. Let's look ahead to week 7. We're going to shift from data analysis to data protection. We will cover database security and access control, role-based access control in Postgres, HIPAA technical safeguards as they apply to database systems, and AI applications in healthcare databases. It's a natural progression. First, you learn to build and query databases, then you learn to secure them. See you next week.